Essentials for caring for peritoneal dialysis patients. This education is developed to provide a basis for care of the PD patient. This training is not intended to replace the judgment or the experience of the nephrology staff or other medical professionals. This education is provided in partnership with UW Health and Unity Point Meritor and is part of a joint agreement for education. Any questions regarding the content may be directed to myself at jcortina@uwhealth.org. The objectives for this offering are to discuss and understand the basics of peritoneal dialysis, gain familiarity with the equipment that we use for our peritoneal dialysis, and identify resources to assist with the basic alarms and troubleshooting. We will describe the basic principles of PD and discuss briefly the common modalities for PD and describe how the structure of the peritoneal membrane facilitates solute and water transport. Renal replacement therapies encompass all methods designed to take the place of the patient's kidney function, and when that function fails or temporarily slows. The glomerular filtration rate, or the GFR, is a test that we use to check to see how well kidneys are working. Specifically, it estimates how much blood is passing through the kidney cells each minute. These tiny cells are called glomeruli, and they work both to filter wastes, remove excess fluid, and help balance pH of the blood. The kidneys also perform and assist with several other endocrine functions. This picture demonstrates the stages of kidney failure. This is put out by the National Kidney Foundation. And you can see that stage 1 is considered normal. So that would be a glomerular filtration rate of 90 or higher. Stage 2 of kidney disease is showing progression and mild loss of kidney function. As we age, we normally have a decline in function. So an elderly person, it would be expected, may have some minor reduced function. Stage 3 is when a patient should have a consult with a nephrologist to make sure that they are receiving the care they need to get as much longevity out of their kidneys as they can. Nephrologists are knowledgeable in doing this, and if there are careful steps taken, they can preserve that kidney function off for many years without ever needing any kind of additional supplemental therapy. When stage 4 kidney disease is reached, decisions should be made about the type of renal replacement that that patient would wish to pursue when they reach stage 5. Ideally, this is a patient-centered decision, and this happens in the outpatient at the nephrologist clinic when the patient receives education about the various modalities. Stage 5 is considered failure. This is the stage that requires patients to have dialysis of some form in order to stay alive, or to have a kidney transplant, or to take a palliative route if that's what they choose to do. Palliative care is also an option that is not often explored with patients, and renal replacement will persist for life, and there is no cure. Discussing treatment goals with patients is essential to gaining their trust and getting the best outcomes for their chosen therapy. The renal diet is commonly prescribed to our dialysis patients, and this is just intended for a quick review. The highlights would be that primarily we're looking at a low sodium diet or a low salt diet. And the reason why we do that is because, back to our science class, salt follows water. And so if they take in a lot of salt and they can't excrete it, they're going to be thirsty and they're going to drink a lot more fluid. It's going to be very hard for them to maintain a fluid restricted diet. And most patients do have a fluid restriction of anywhere from 1 to 2 liters per day. They also need to have a low potassium diet. And you might say, well, what foods are high in potassium? Molasses is very high. Apricots, bananas, oranges, cantaloupe, honeydew, avocados, chocolate, raisins are just a few items that are very, very high in potassium. Low potassium choices would be eggplant, carrot. They also need to avoid having them eat a lot of phosphorus in their diet. So foods that contain a lot of phosphorus are going to be dark colas, nuts, dried beans, and all dairy products are high in phosphorus. The reason why we want to avoid phosphorus is it cannot be readily excreted with failing kidneys, and as that phosphorus climbs, The body is going to try to match that with calcium out of the bone in order to do this. So this facilitates bone disease in our patients. So that's why it's important they get their phosphorus binders like Sevelamer with their meals so that it goes into the intestine and binds that phosphorus so that it's not absorbed. Have your patient eat a diet that's high in protein. Patients who get adequate protein stores tend to have higher albumins, and patients with high albumins tend to recover when they get sick. And our patient population has oftentimes many instances where they're hospitalized and need that extra protein to recover. So why do we want to do peritoneal dialysis? This has great survival benefit for our patients. Peritoneal dialysis acts more like a natural kidney, exchanging fluids in the body compartments and removing those waste over a long period of time on a more regular basis than what a patient gets with hemodialysis. Hemodialysis is only 3 times a week and is only for 3 to 4 hours. That would be like having kidneys that function for those periods of time. So it's much harder on the body to have it done quickly as opposed to just gently over time. It also makes patients less likely to not tolerate their treatments because they have much less instance of nausea or cramping, and they tend to have better appetites. Peritoneal dialysis patients generally have less dietary restrictions due to the frequency of their treatments, and this allows for a healthier diet that is more inclusive of fruit, vegetables, and fluids. Hemodialysis in-center is very time restrictive. Patients must attend at least 3 times per week, and it often interferes with patients maintaining jobs and activities of daily living. Travel must be prearranged, and peritoneal dialysis is set up as a home therapy that's intended to run by patients, and it makes it much easier for them to be able to pack their supplies and go on trips. One of the best advantages to using peritoneal dialysis is that it helps preserve what kidney function the patients still have left. So if they're still making some urine, it will allow that kidney to still do that. Why do we worry about preserving residual kidney function? Why is this a top priority in dialysis clinics? Kidneys working 24 hours per day, even at reduced capacity, are providing patients with additional clearance of waste products and fluids that they would not otherwise have without their kidneys. This minimal function can be a significant difference in how a patient feels and their ability to have a less restrictive diet and fluid plan. Most of all, these patients have a significantly lower risk of death. Each 250 milliliters of urine per day is associated with a 36% lower risk of death. PD treatment plans center on the amount of kidney function that the patient still has remaining, and then that factors into the amount of dialysis that they receive. Promoting residual kidney function contributes significantly to the overall health and well-being of dialysis patients. Preventing peritonitis is impressed upon patients performing peritoneal dialysis. Every episode of peritonitis has a lasting impact on the function of the peritoneal membrane and decreases the likelihood that the patient will be able to continue on PD. It also increases the likelihood of recurrent episodes. Patient signs of peritonitis include cloudy fluid, fever, chills, and abdominal pain. The kidneys are very sensitive to low blood flow. 20% of all cardiac output goes directly to those kidneys. Any interruption in blood flow will have an impact on their function. In a new study, researchers found that both uncorrected and corrected serum calcium levels of 12.2 milligrams per deciliter and above identified patients at risk of premature death. Urinary tract obstruction is a blockage that inhibits the flow of urine through the urinary tract and can be complete or partial. Blockage can lead to kidney damage, stones, infection, and failure. Nephrotoxins are substances that are harmful to kidneys. Common hospital medications that are nephrotoxic and should be avoided include NSAIDs, cyclosporin, beta-lactam antibiotics, chemotherapeutic agents, aminoglycosides, contrast agents for radiology. ACEs and ARBs are medications that are especially helpful for kidneys that are leaking protein into the urine. They also act by lowering the blood pressure. These medications slow renal function loss and decrease the risk of heart attack or stroke. PD catheters are typically inserted 2 weeks before use. The catheters used are most commonly silicone and have 2 cuffs. One cuff is buried deep in the abdominal muscle, and the second cuff is in the subcutaneous tissue about an inch from the surface. The cuff should never be visible. Please, if you see the cuff, notify the dialysis nurse. The PD catheter is coiled and contains many pores to help with the exchange of fluid. The coils reside deep in the pelvis. PD catheter sites require daily care. The International Society of Peritoneal Dialysis recommends daily site scoring and application of gentamicin cream to the insertion site. The care is provided by the dialysis nurse or other trained staff member. If the patient has a catheter and is not yet using it for dialysis, please notify dialysis for site care. They may also need to flush that catheter weekly. Constipation will prevent the catheter from functioning properly. It is recommended that patients on PD have 2 to 3 stools daily. External parts of the PD catheter include the surgically placed PD catheter, the transfer set, and the mini cap. Patients with PD catheters are at very high risk of peritonitis with any breech in aseptic technique. All nurses caring for PD patients should check the catheter as part of their assessment. Avoid tugging or pulling the catheter. The catheter should be secured to the abdomen with paper tape or a PD belt per patient preference. Attached to the PD catheter is the PD transfer set. The purpose of the transfer set is to adapt the catheter for the type of equipment used for dialysis. Shown is a Baxter transfer set. This is the type of set that we will use at Meritor. Fresenius is another brand with a different type of connector end. The Baxter transfer set is a twist and close type of device. The Fresenius is a simple clamp. Both types must have a cap snugly on the end when not in use and should either be turned closed or clamped. Report any and all episodes of contamination to the dialysis nurse immediately. PD catheters that are found with open ends or separated from the transfer set will require urgent care from nephrology. Many of these episodes require installation of antibiotics to prevent peritonitis. This is the site scoring tool put forth by the International Society for Peritoneal Dialysis. It's recommended that this tool be used every day to check for potential for infection or other problems. And this should be conducted by staff who are very familiar with peritoneal sites. So this will be conducted by the dialysis nurse every day when she or he does the site care. Guidelines are to score the sites daily and notify nephrologists for scores of 2 or higher. The guidelines also recommend that sites have gentamicin cream to the site to prevent infection. Ointments are never used as they break down the catheter, and this can cause leaks. Infections can start at the site just like with a central catheter. Please notify the dialysis nurse of any PD site complaints from the patient. Continuous cycler-assisted PD, or CCPD, is the most common method for performing peritoneal dialysis. This requires the use of a cycler. The dialysis nurse will set the patient up for the night with the set amount of treatment time that will include a number of cycles, and the patient will be disconnected in the morning. Some patients will have fluid left in the belly during the day while others do not. We call this a last fill. Some patients do continuous ambulatory PD. This is a manual method. Patients will connect themselves and drain their abdomen, followed by a fresh fill of dialysate. When the exchange is complete, they disconnect until the next exchange is needed. The number of exchanges and the amount of time between exchanges will be ordered by the physician. Very few patients maintain this type of dialysis. It is labor intense. Most patients switch to the cycler while in the hospital. If the patient desires to perform these manual exchanges, they must be evaluated by the dialysis nurse for technique before they can be granted permission to do this. This is especially important if the patient is admitted with peritonitis. Peritoneal dialysis consists of 3 phases of treatment called a cycle that occur repeatedly throughout the patient's day. This can happen with a cycler or can be performed manually. The first step in a cycle is always the drain, where the fluid is removed from the abdomen, the fill, where a prescribed amount of fresh dialysate is instilled into the peritoneal space, and the dwell, or the amount of time that the dialysate is left in the belly to do the exchange. Peritoneum is the membrane that surrounds our abdominal cavity and covers all of our abdominal organs. It is very thin and porous. The membrane is full of capillaries that feed the peritoneum. Capillaries also contain pores that allow the exchange of nutrients and oxygen. The peritoneal membrane, with its capillary network, allow for bidirectional exchange. Solutes like sodium and BUN readily cross back and forth between the peritoneum and the blood vessels. Large particles like glucose move more slowly across the small holes. Red blood cells are too large to slip through into the peritoneum. We use this membrane to work as a filter for exchange for wastes by altering the concentration gradient of solutes in the abdomen. Two of the mechanisms that are involved in the clearance of wastes in peritoneal dialysis are diffusion and osmosis. The peritoneal lining is super thin, like the paper of a tea bag. After clean dialysate is infused into the peritoneum, diffusion begins. It is the movement of solutes or particles from areas of high concentration to areas of lower solute concentration. Outside of the peritoneum is much higher concentration of waste particles like potassium and BUN, and they easily cross the semi-permeable peritoneum into the clean dialysate, but large particles like blood cells cannot cross. Wastes accumulated in the dialysate are drained off in the dialysate that is drained in the next PD cycle. Another method of clearance is osmosis. Osmosis refers to the movement of water. Notice in the picture how one of the eggs in the containers looks shriveled and the other ones look swollen. The shrunken eggs are in a high glucose solution, causing the water to move from the inside of the egg to the outside. In the container with the swollen eggs, it is plain water, causing water to move inside of the egg where there is more glucose. In PD, dialysate contains glucose, which is a large particle that can cross the peritoneal layer, but not easily. Glucose attracts water from the other side of the peritoneal membrane. Water moves from areas of lower glucose concentration to areas of higher glucose concentration, and the dextrose contained in the dialysate is what primarily draws water into the abdominal compartment in peritoneal dialysis. The stronger the dextrose used, the more water will be removed with the treatment. Fluid removed during treatment is referred to as ultrafiltration. Fluid can be absorbed by the patient too, like if the patient has a very high glucose. It is important to note the clarity and color of the PD drained fluid when you are assigned a PD patient. While you do not have to set up the patient or disconnect, cloudy fluid is much like a patient spiking a fever. If you notice your PD patient has cloudy fluid, please page the dialysis nurse and let her know. The bloody bag is from a patient with hemorrhagic pancreatitis, where a proteolytic pancreatic enzyme causes the destruction of red blood cells. Women who are menstruating may also have bloody fluid like this picture. Fibrin will appear in fluids like floaters or have a jellyfish-like appearance. Patients with fibrin in their fluid should have heparin added in their dialysates for the next treatment in order to prevent their catheter from clogging. The dialysis nurse will take care of this. Cloudy fluids should be reported immediately to the dialysis nurse, who will discuss follow-up with the nephrology team. Please do not hesitate to page the dialysis nurse at 0029 if you note problems with the effluent. This requires a cell count and culture by the dialysis nurse as soon as possible. Peritonitis treatment needs to happen quickly. This is a cycler used at Meriter Hospital. It is the Baxter Home Choice Pro. The interface is simple to operate and consists of only 5 buttons. The green Go button starts and resumes treatment. The red Stop button mutes alarms and pauses therapy. The blue Enter button is for selecting choice and entering menus. Please note the alarm and press the Stop to silence, then notify the dialysis nurse at 0029. Manual draining is a function that is available if patients are taken off treatment before their cycle completes. There could also be other reasons for doing this, such as patients leaving for procedures or complaints of pain or emergencies. This can be done when the machine alarms low drain if you see the machine has not drained adequate fluid off. You can see the steps are simple. You press stop, arrow down to the statement manual drain, and then press enter. Please call 0029 and the dialysis nurse can talk you through this if this is ever needed to be done urgently. In cases of power outage, after 30 minutes of failure, an alarm occurs to alert the patient that there is a power failure. Press stop to mute the alarm. The machine will also alarm when the power returns. If power is restored within 2 hours, green go button will resume the treatment. After 2 hours without power, the treatment cannot be restarted and must be discontinued. So the unit nurse responsibilities are going to be to notify the PD nurse on call anytime there are any issues with signs or symptoms of an infection or problems with the machine. Daily weights are an important part of that assessment piece that you would normally perform with a patient with end-stage renal disease. And a full fluid status for overload or dehydration is also important. As discussed earlier, you want to avoid dehydration to prolong that kidney function. And of course, overload has its own set of symptoms that we are concerned with our dialysis patients. So fluid overload can cause difficulty with breathing, hypertension, etc. Over time can contribute to heart failure. So we want to make sure that we maintain as good of a fluid status as possible. Monitor vital signs as ordered by the physician in any time that you have any concerns. And that exit site and line assessment are going to be to make sure that the exit site is appropriately dressed and that the catheter is secured in some way to the belly so that it doesn't become dislodged or pulled on. And when the patient's in treatment, to make sure that you take a look at the effluent and assess for any cloudy fluid. The dialysis nurse's role is always going to be to set up the treatment as ordered by the nephrologist, and we also do a fluid status assessment and contact the nephrologist as needed for stronger solutions. We take care of the connecting and disconnecting, and we also assess the PD effluent. We will be taking care of the exit site scoring and assessment and a line assessment. We also assist with managing alarms and take care of the PD cycler documentation. So as far as resources go, you're always going to be able to contact the dialysis nurse. We have a nurse who is staffed all night long. So we have somebody here 24 hours a day, 7 days a week. And she has 2 backup people that she can also call if she needs help. So don't hesitate to call us and page 0029 if you need any help. We can walk through most situations on the phone if you're willing. The dialysis nurse may ask you to have the patient reposition or look for kinks, and sometimes those problems can be easily solved. Otherwise, we're happy to come over and help when we are needed. Thank you.